some time for folks to work on it. So good morning, everyone. Thanks for joining us. I'm not sure who we have online joining us. Wanted to, before introducing our two speakers today, just let everyone know we've been going through a process since December of trying to look through this Friday morning seminar series and add some more structure to it and this idea of a two-year curriculum. So a lot of attention to this has really been a well-attended venue, a lot of good feedback about the value of it, and trying to add some more structure so that as a lot of folks are here on two-year T training grants or K training grants, we really have a curriculum over those 2 years to ensure we're covering topics that are of most importance. In terms of the larger framework and structure of that, I've talked about kind of 3 tracks. One being talks that are more methodologically focused in the T3, T4, pop health, health services, outcomes, HSR, whichever term you want to use, kind of in that space. So things that are more agnostic to any disease and focused on methodology, be it sampling, recruitment, design, evaluation, analytics, epi-biostats. So those kind of methodological track and those kind of talks, thinking about over the years, things about biostats, sample size calculations, structural equation modeling, conceptual models, things that are really kind of more methodological. The second track being more career development topics. So things that are not methods, but kind of bigger career development. So last week kind of introduced what was going to be a new seminar series, kind of this professional journey. So Mike Sad came and joined us and talked about his journey from going through pre-doctoral and post-doctoral training to his successes now, and the idea that it's really a circuitous path, that most folks, we see them up in these prestigious positions, but hearing kind of how they got there, a lot of insights can be gleaned from that. So as part of that series, as well as things like team science, a whole number of things, that are kind of writing an abstract, things that are more kind of career-oriented, timelines, the panel discussions we've had with alumni before. And the third track being more works in progress and practice presentation. So I think, we've always had works in progress as part of the series. And the expectation really wanting to be one of, especially for our AHRQ T32, the K12, KL2 scholars that are in the T3, T4 space, really doing a works in progress twice a year. So hopefully we'll be able to have some structure where early on between August and October, folks that are both new in their first year as well as second year, kind of giving talks about here's what I'm doing, here's my science. And then in the second half of the year, kind of as we enter now the second semester, kind of coming back and giving an update. Have had a lot of representation from faculty like Emily Levitan, Andrea Charrington, as well as recent scholars. So Anand's been really critical with this, Kelly Kenzik, Ellen Eaton, others. So really trying to kind of add some more structure. So more will follow on that, and we'll want to kind of vet that with everyone to get feedback. Again, trying to take what's been a really good series, add some more structure to it, pursue the possibility of could it be credit earning. So a lot of things in the works around this Friday morning series. So beyond that, we've talked a lot about the works in progress and what their purpose should be and trying to add a little more structure. I think we don't want to add too much structure, but when we do these, really want to have 3 speakers with 30 minutes each and have talked about ideally about 10 minutes of presentation and 20 minutes for feedback. And I think that thinking about works in progress, at least the way we've operationalized it, and at the end if we have time to maybe talk more about it as a group, is this is a chance in this room to get feedback wherever you are, whether it's designing, whether you're evaluating your data. So thinking about a works in progress as not an opportunity to kind of, it isn't the same as preparing for your talk at a national meeting or here's what I've done, but places where you really need critical feedback. So an opportunity where you have people in the room with different backgrounds scientifically. So a mix of kind of here's where I am, but also an opportunity that things aren't so far along that you can't get a great suggestion and go, wow, that's a great idea for my next study, but you're actually at a point where you are with the science that you could integrate that into your analysis plan or in some other way. So again, we don't want to be overly prescriptive in this, but I do think we want to take advantage of the fact that we've got such a good group in this room and want to avoid kind of works in progress where we give 20 minutes of background slides, spend a little bit of time on our science, then the 30 minutes is up and you really can't benefit from that feedback. So really kind of going to look to add a little more structure, and we'll talk more about that. And again, we'll want your feedback. So with that said, thank you guys for coming and kind of being willing to have a little bit more structure with a shorter presentation, about 10 minutes within the 20 minutes for feedback. And we'll hear from both Dan Chu and Anand Iyer, who are both two of our first-year K. And Dan, you on the K12 or the KL2? K12. Okay, I guess there's so much similarity. So, and you're on the KL2? Oh, K12. Okay. So, and we have a mix of folks. So the K12 is a P-Corps funded 2-year grant. It's going back in for recompetition like next week. That Ken Sag is the PI on. It shifts over time. So this last one was more comparative effectiveness. It's moving into a learning health system model. We also will have in our group KL2 scholars, which is through the CCTS, and that kind of includes both folks who are doing early translational work. Probably won't see them in this venue quite as much. There'll be other venues, but the folks that are doing T3 and T4 research in the KL2 program will also be here to present with us. But I forgot that both of you guys were on the K12 because there's we reviewed them together and there's so much overlap. So with that said, Dan, thanks for joining us and look forward to hearing about where you are with your K12 work.
Thank you. Great. Well, thanks for this opportunity to talk a little bit about my project. The title is Understanding Disparities in Surgery for African Americans with IBD through Health Literacy. I am year 1 to 2 on the K12. I do have a target for K23 for this June, hopefully, and I'll talk mainly about the research plan today. So just a quick background, inflammatory bowel disease, for those who aren't familiar with this, includes both Crohn's and ulcerative colitis. It's a terrible disease and affecting more and more people in the United States and across the world. Very expensive for direct costs, indirect costs to the hospitals and to patients and their families. There's no cure, and unfortunately we really don't know why this happens to individuals. What's interesting about this disease is not only is it chronic, but it also involves surgery. So a lot of patients with IBD face decisions about major surgeries involving entering the abdomen, rearranging the guts, even creating what we call stomas or ostomies that may be permanent sometimes. Now what's interesting is that everyone in this room is familiar with health disparities, but health disparities also exist in surgical outcomes, and we term this surgical disparities. These exist in things like mortality, post-op complications, and things like length of stay. And IBD in particular is what we call worst of the worst of all the kind of surgical diseases. And what we've noticed here at UAB is that African Americans with IBD in particular have disproportionately worse outcomes in some of our studies. So the question we had is, why does this happen and what can we do about it? And this is how we got into health literacy. So about 3 years ago when we first came, we implemented a program at UAB called ERAS, or Enhanced Recovery After Surgery. And all this is basically, it's 18 to 20 different processes that we start the minute we meet a patient in clinic that we consistently deliver to the patient through their entire perioperative stay. Things like education, things like having patients get multimodal analgesia, avoiding narcotics, walking the night of surgery, eating the night of surgery. And ERAS has been shown to improve surgical outcomes, mainly in northern Scandinavian countries and in clinics in the US like the Mayo Clinic, which is very homogeneous in populations. But what we showed here last year was that ERAS essentially eliminates previous disparities that existed in patients here at UAB. And not only does it reduce the disparity, it also improves outcomes for both black and white patients. And the question is, why does this happen in the pre-ERAS period, which is really just 2015 and before? And so what we kind of asked is, well, we probably weren't doing something in the pre-ERAS era that we were doing now with ERAS. And one of the things that we focused on was education. So the idea was that, well, maybe better patient education was being provided with ERAS. Maybe we had clearer expectations. Maybe there was more engagement. And then you use all these terms, and then this idea of health literacy comes around, which is the idea of obtaining, processing, and understanding health information to make decisions. And so that drove our question. What is the role of health literacy in determining surgical outcomes and maybe even disparities for patients with IBD? And probably some in this room have worked with health literacy, and we've seen this a lot in non-surgical entities and fields. But really the idea of it being applied to surgery is still pretty new. So this is the model that we used for our grant. It's taken from Dr. Wolf. But essentially what this says is that, well, a patient comes to your clinic with a set level of health literacy. This is determined by several factors before the patient even came to you. Social determinants of health, certain demographics. And what happens though is that there are factors that we can modify at the system level, at the provider level, and even at the patient level that can basically kind of mediate or modify some of the patient to help determine an outcome. So the idea is that there may be some discongruity between this. Someone comes in with low health literacy and you have a readability of information that's like at the 12th grade reading level, that doesn't match. And so this patient may have a poor outcome because the patient just doesn't simply understand the material that you're giving them. And so the aim of this project was really just threefold for this K12. One was simply just to assess health literacy in the IBD population. There's actually no published reports on this. We really don't know. We hypothesized that there was. So our aim one was to assess literacy. Aim two was just to associate health literacy with surgical outcomes. We have a very robust IBD practice here at UAB, and so we have many patients undergoing surgery. We have a lot of outcome measures. So the idea was that maybe we can actually link this to health literacy. And then the last aim was a qualitative one, was to assess this modifying factors, to see at these levels, are there certain barriers for patients with low health literacy that we can maybe target in future interventions. So this is specific aim one, and what we did is we assessed health literacy in both African American and Caucasian American IBD patients through our Kirkland clinic with 3 levels of 3 surveys, or instruments, I should say. These were the instruments, the Realm SF, which is probably the most popular one that's used across the world, developed by Terry Davis. This measures word pronunciation and understanding. The S-TOFLA measures comprehension, and then the NBS, the newest vital sign, measures numeracy. So there's different levels of literacy that you can measure, multiple dimensions. So we thought these 3 would be a good way to get at all of this. And feel free to interrupt with any questions, okay? So the difficulties that we anticipated for this was, one, recruitment, simply recruitment. Would patients actually want to undergo this test, because it's sort of the test, both for African Americans and Caucasians? The other question we had was, does this interrupt patient flow? Kirkland Clinic is a very busy clinic. How much time does this take giving 3 instruments? And then, of course, the idea of, do we have the power to detect differences between African American and Caucasian Americans? And we had to use reports in other fields to try to estimate how many patients we might need to determine a significant difference. And this is really just one study that looked at this TOFLA and saw a difference of these percentages, and we basically back calculated that you might need this number of patients at the minimum to detect a difference. What we found is that recruitment of patients we didn't have that many barriers to this. We have many studies ongoing in our clinic, and we have a great staff that help with this. So our recruitment was fairly straightforward. And then the patient flow, we realized all 3 of these basically took less than 10 minutes to administer. So it didn't really interrupt the flow that much. So we started this back in August, September. We do have some preliminary data. We have about 120 patients now that have been surveyed for health literacy in IBD. What you can see here is the 3 different instruments. What's interesting is that the newest vital sign, which is the most common instrument that's administered in surgery, as we found on review, you can see 55% of African Americans have limited health literacy by NBS, and possibly inadequate 10%. So there was disproportionately a higher number of African American patients with IBD who have low health literacy by the NBS. The same thing with the Realm SF, higher percentages here for African Americans. And then with the TOFLA, we actually didn't see that much of a difference. It was higher, but not statistically significant. Most patients had adequate measurements by TOFLA. I'm not quite sure how to explain this right now. I'm still looking at this. We're talking with my mentors, Terry Davis, to see if they've observed this in other fields. When you stratify this even out a little bit more in terms of the NBS, you can see that there's 2 clusters, there's 2 lines. The top line essentially describes Caucasian Americans. The bottom 2 lines describe African Americans, males and females. And this is over age also. So as you increase in age, also the literacy measures seem to come down. And this is what my mentors would have predicted, and Mona predicted this too, that she thought African Americans, older African American males in particular, would have the lowest health literacy. So this is interesting to kind of see within the IBD population. And you can see the same kind of clustering with the differences between Caucasian Americans and African Americans with the Realm, and also with TOFLA. So this is some preliminary data, basically. It suggests to us that low health literacy probably exists in IBD patients. Seems to be more common in African American populations, and in particular, the older African American male may be at particularly high risk of having low health literacy. And I think this is helping us inform us in the future what we target. This is just a side study that we broke off in terms of readability. We looked at information across UAB in terms of all the surgical specialties to say the information that we give patients. Where is it? Using the Flesch-Kincaid measurement instrument, you can see that basically all in green, almost all specialties, all the reading materials are much higher than what the AMA recommends at the 6th grade reading level. So that's an area opportunity for improvement. So I'm going to talk a little bit more about just more plans now for our other aims, which are in progress. Specific aim 2 was to determine the association of health literacy to IBD. And of course, we hypothesized that low health literacy would be associated with worse surgical outcomes. We picked these 3 measures because these are 3 common metrics that we look at within the hospital system. We didn't look at mortality because it's so low for surgery nowadays, but 30-day readmissions, post-op length of stay, and even post-op complications are kind of big metrics that we love to look at. The study itself is basically quantitative using multivariate analyses. We'll take things like readmissions, split them into patients who are readmitted, patients who are not readmitted. We look at different factors. Is the plan to look at patient factors, things like race and ethnicity. We'll look at procedure factors. We'll look at literacy levels, which we'll be measuring. And then we'll do unadjusted comparisons then, and hopefully use some multivariate analyses to try to see if there's any associations or independent predictors for someone who might get readmitted. We do the same for post-op complications, which is also a yes or no type of metric. And then post-op complications is a continuous variable, so this will be a little bit different analysis. So several difficulties we anticipate with this. One is just, again, the power issue. Will we have enough patients to even detect an association, not fall into this type 2 error? So we use data from other literature of our own. We have some data suggesting that African Americans have a 2-fold increased risk of readmission. So colorectal is kind of a bad specialty. Patients get readmitted a lot, 10% readmission rates. Some of our studies, African Americans have a 20% readmission rates. So based on that kind of difference, we kind of back calculated that we need this many patients basically to try to detect the difference of about 10% for things like readmissions. You can see this seems like a lot of patients, 450 patients. We have a pretty high volume at IBD, so we anticipate kind of accruing to this point in about a year and a half to getting this target. So that's our goal. Patient recruitment, we're worried about, but I think we figured that out with the system that we have now in our clinics. And then the last aim is a qualitative one. So this is totally new for me. This is part of my training and career development, exploring factors that might impact low health literacy. We expect to find barriers. We've already looked at readability, and that's definitely something that we can improve upon. The way that we set this up is I work with the Crohn's and Colitis Foundation, which is the largest patient advocacy and education group in the country. We're setting up an IBD, what we call an advisory panel, with both patients, various stakeholders, and to kind of develop various interview guides that we'll use for our aim. We have a couple ideas. One is to use focus groups, start with 6 to 8 focus groups, purposely sample into both white patients with IBD, black patients with IBD, and then conduct focus groups this way. And then also looking at stakeholders. So these are not just physicians, but also there's a huge nursing staff that's involved with taking care of IBD, ostomy nurses, community educators. And so we'll kind of look at this population, this group, to ask, what is it about the surgical process for IBD that we could do better? What can we improve upon? There's some of the buzzwords I'm using here, but we're going to try to go up from just going with a kind of a blank mind here, try to build up an idea of different themes that might come up. Ultimately develop better understanding in the context of some of those conceptual frameworks I showed earlier. And this will help ideally inform us about our next steps. Difficulties here is with recruiting. Who will come to a room for a focus group, especially with the minority populations. We have great help though and great advice from the Minority Health Research Center and the focus groups that they run here. We've actually had experience with another grant running focus groups. We've already conducted 6 focus groups there. So we've kind of worked out some of the logistics of that. So I don't anticipate too many problems here. And the same thing goes with the stakeholders. So we do have some experience that will make this a little easier for us with this project. So the big questions for me, we have the K12, so the aims are there. But is my anticipation of going to a K23? The idea with K12 is that I could begin to understand some of the mechanisms and how health literacy might play a role. And for the K23, my idea initially was that basically going towards implementation, developing a way now to intervene or to enhance kind of health literacy. And I guess some of my questions for the group, and we don't have to make a decision here, obviously, because this is my cross to bear here, just defining this. But like in terms of interventions, should I focus on one intervention, like readability, which I showed you earlier? Is clearly there's a big discrepancy between what we give patients in the clinics to where patients the recommended readability, or do I do a more comprehensive type of development, like a come up with a fancy acronym for a comprehensive approach towards addressing kind of all those levels at the provider level, things like communication, address it at the system level. Is that something I should go for the K23, or just focus on one thing in particular? None of this would be possible without support of the Department of Surgery. I have a great team here with Isabel, Amanda, Lawrence, Katie, and Emily, who really kind of have really kind of got this going for me in the last couple of months here in the clinic. So if you haven't taken questions and suggestions.
Yeah, thanks. That was really fantastic. Nice synthesis of that. Thank you. So let's open it up. Any clarifying questions or?
In your clinic, you said you already do, there's a lot of research being done already.
Yes.
Do you all look at patient-reported outcomes too? I'd be curious about, that impact as well.
Yeah, so not within my clinic in terms of patient-reported outcomes. We've just started looking at opioid use. So that is something that we've gotten some iPads. This is a separate project, gotten iPads and have developed kind of a survey that we're giving the patients to report for themselves. So we're moving into that area, but for IBD in particular, we haven't had any kind of patient-reported outcomes. But I think, it's something that I think is going to be very important to do. We've actually just implemented a program called Seamless MD. It's a Toronto-based program. It's a patient-based app. It's internet and also on their phones that now tracks, that helps patients, the minute you meet them, they install it on their phone, and it actually follows all of these processes with ERAS and educates patients and prompts them throughout time based on when their surgery is, and will ask them certain questions. This group really does a lot with patient-reported outcomes. So we're going to move into that eventually.
So I guess I want to start here and then maybe go back to the first set of data. So I guess one big question that comes up is, you're talking about developing an intervention, but you started off showing us that ERAS attenuates its health literacy or other factors that are causing these disparities, at least for length of stay, that you already have an intervention that attenuates these observed disparities. So I guess the first question is, I think, just making a compelling case for, in the context of ERAS attenuating, at least in length of stay, disparities, why is there a need for another intervention?
Yeah, so, well, we think that ERAS was developed, all the different processes in ERAS are basically best evidence surgical practices or processes that individually have been shown to improve just overall surgical outcomes. So it was novel that we showed that it actually can reduce these disparities that are there. So yeah, we are working backwards, but we think we can do better, basically, than what ERAS is doing. Even though it's improving some of these disparities in length of stay. Things like complications, we haven't quite seen the same dramatic effect. We think we can almost tailor ERAS even more to things like the education piece with the readability. That ERAS right now assumes that education is good, but we don't think it's adequate enough.
And that makes sense. And I think just being mindful, because I think you might have some reviewers say, you've got this wonderful thing, so I think you're thinking about it right and kind of being, clearly showing in the significant section, while we've made progress here, we haven't made progress here. And maybe you might go back to that preliminary data. I think that was really, really interesting to see just the variability. Do you know, in the surgical or non-surgical field, how many folks have administered 3 different instruments to assess literacy or numeracy?
So we actually just completed a qualitative review of all health literacy research in surgery, and there's basically in health literacy about 21 papers that have been out there since 3 years ago, and they've all used basically single instruments. So no one's really looked at multi dimensions of this. Because it's really just that you look at TOEFL, if we just use the TOEFL here, we'd be like, oh, okay, everything's relatively similar. But then you look at these, and I'll tell you right now, if you take these tests yourself, the NBS is hard.
I did the NBS,
It's not easy. It's a 6-question. You have a nutrition label, and you have to answer all these mathematical questions and calculate things. And so the NBS, so there are differences too in instruments.
And just thinking about the bigger question about where this goes, I don't know if there's access on the team or someone on campus that does really good psychometric work. It just seems like right here you've got such a rich data set to evaluate just the differences by race and other factors across these instruments, and trying to think about guiding, where this goes. To your point, like the TOEFL is really what would mislead you in terms of, if you really believe there are these distinctions, and between the realm SF and the NBS, is there something that is more on a numeracy dimension than a literacy dimension that is in terms of the target for intervention? And I mean, to me, it's just striking these differences, and that if there is the opportunity to really, with someone that understands psychometrics, is to really understand or further explore the differences across these instruments, and might that also help guide you in terms of focusing and attenuating disparities on one of the NBS or realm where you really see these differences, and seeing, I guess, in the AIM-2, how in AIM-2 you're assessing the same three.
So basically, so we're going to assess a 3 for 450 patients is our ideal goal here.
I mean, so the ability, and it would, I mean, you couldn't probably include much of this in in June, but to look across those three instruments and how they associate with these outcomes.
Right.
And I mean, like in terms of just trying to guide, and then bringing that to your qualitative work is just, I think, really fascinating. And that initial discovery suggests there's something going on there. I mean, with these instruments, at least in this population.
Yeah, and this association, people, so, a year ago there was like no data out there in terms of this association, but probably a few months ago, Vanderbilt just published the first paper really in JAMA Surgery that actually associated another metric. They use a 3-question survey for brief literacy survey, and it basically just says yes or no whether you have low health literacy, and they were able to associate it with a few hundred patients in their major abdominal surgery patients, and so that low health literacy is associated with longer length of stay. So it's like the first kind of relatively large data set to show some associations. And we would, I think, there are probably people in the room who are very familiar with diabetes and hypertension and the role of health literacy in those fields. And I think people have shown the associations with outcomes there. So we expect, hypothesize there would be something here.
Good presentation, man. I have to see if I can keep mine as succinct as your two questions that go to your last slide about future directions.
Yeah.
I'm in that same zone. We have Gabrielle here and other people that have done the K12 and moved to the next extramural K. One thing I would recommend, at least as a basic qualitative course, I took Janet Turan's qualitative course in the School of Public
Health. I just finished that. Yeah.
So
in December.
So she was able to look at the aims and kind of make sure the qualitative methods were sound. So that's going to be important that you kind of incorporate that. And that helps you design the K23. And where are you looking to send that where are you trying to apply for that K23?
So the NIPDK.
Have you spoken to a program officer?
I spoke to them a year ago.
Okay.
Yeah, and it's on my to-do list for this month.
I think that would be important
just to make sure.
To decide that particular question about, are they seeing a single intervention versus the comprehensive care intervention as something that's feasible that they might be willing to look at. That was important for mine when I spoke to a program officer too. What is feasible in their realm of funding? You might need prelim data to show something works, or you may make that one of your aims in the extramural K.
Yeah, and that was my chief concern. Yeah, I don't want to buy too much too, and just say I'm going to do so much and be unfocused, as opposed to one clear kind of target.
Can you speak a little about what you did to make sure this didn't interfere with clinic flow, and who?
So actually, Isabel and Mandy right here have been kind of running, helping, and Sam and the whole crew and Lauren there. Yeah. So what we did is we piloted, like we do a lot of our tests just in one surgeon's clinic, so that if it messed up, like only one person would be mad. And that was basically me. So we tested in our clinic first. We put together the 3 instruments. We actually chose instruments too, not only for the multi-dimensions, but also like we used the short forms for all of these, because as opposed to a 20-minute test. The realm SF takes 30 seconds. The NBS takes like 6 minutes, and we were worried it would go up to 15 minutes, but we put the 3 together, and then we just basically just let it go in the clinic. And the thing is with my clinic is we have like 6 rooms, so there's always patients waiting, and so they're not really kind of doing anything except waiting. So we found that we can approach those patients while they're waiting, administer a survey that takes less than 10 minutes, and it really doesn't affect flow, at least so far that we found. I don't know if you guys have any thoughts on that. Yeah. No problems.
Are you doing it with paper and pencil, or are you doing it electronically?
Paper and pencil.
And then running to a database on the back end?
Mm-hmm. Oh, do you have another question, or is that?
No, that was it. Yeah. The next question here. Yeah.
Yes.
So apologies if this has been mentioned at the beginning. So there's a research group in health services that's doing a lot of work about health literacy and readmission. So for that component of your grant, it might be worth reaching out to them. Dr. Carroll and Dr. Madonna, I believe is.
Oh,
Yeah. So they're doing a lot of work and that's putting together a systematic review.
What department or division is it?
Health professions. Robert Weecham Maldonado in School of Health Professions. I'm not sure which department.
Could kind of help inform maybe the variables that you use in your risk-adjusted model for the
Yes.
readmissions part.
Yeah. Oh, interesting. Yeah, I didn't know that.
Yeah, can we go back to your conceptual model?
Yes.
Which I really like. So for the AIM-2 study, aside from the health literacy with the 3 different instruments, are you doing any other assessments? Are there any other is there any other questionnaires that you're doing, or other domains that either link up? It's one thing that comes to mind thinking about surgery and outcomes is social support. I mean, just the ability of caregivers. So just wondering if there's things like that are being captured or measured systematically with either some instrument or some other way.
Yeah, so not systematically right now that we're doing, but that's a great point. Because yeah, you're right. You look at what kind of help determine health literacy and social support clearly plays a role.
Yeah, and maybe just thinking for the future. I mean,
Yes,
I think being
good.
focused makes a lot of sense. But thinking, and then also towards interventions, right? I mean, it might be that part of it is a numeracy or literacy focused intervention, but it might be delivered through a caregiver, significant other, or if that doesn't exist, through a peer, or what I mean, just trying to think around other domains and dimensions.
Yeah. That's a good point. Yeah, that's something we actually observed just this week when we enrolled this Seamless program. This is a fancy kind of electronic program you put on the phone. We were worried, for the Canadians, do you really understand? Our patients here, some of them have no means whatsoever, right? Some patients don't have no internet at all.
Right.
And so what we found this past week, we asked some patients yesterday, is that their social support, their mothers were logging into the programs and doing things.
Yeah, no, in other fields along those lines, I think I've seen where technology, especially when you have challenges with literacy, or even I know the digital gap is shrinking, but there's still a good number of folks as you get older that don't feel comfortable, even if they have a phone, with having software interfacing around medical things. So I've seen effectively, whether it's endogenous support from identifying a significant other, or exogenous, assigning a community health worker peer as kind of the bridge between the health system, the patient, the technology. I mean, it's almost having someone that's the translator. So, you can kind of deliver that technology, and it sounds like you've, observed that happening naturally, I mean, in terms of some of the patients with the Seamless program. We're just thinking about potential, intervention design. You know what I mean? Like, I'm thinking about, I've seen some neat things done where people actually go through this rigorous methodology to identify, within my social network, who would be the best person to be my navigator. There's some cool stuff out there.
Yeah, and that's the idea too we thought about, is this idea of the navigator, because I know the UAB has such a big navigator program in the cancer departments, whether that can be applied into the surgical realm is one idea that's been floating around.
Yeah, and I think that if navigator, health worker, I mean, it's similarities, but then and kind of neat models, arming a navigator with technology as another kind of thing. So you've got technology, and as a navigator, just not navigating the health system, but navigating the technology to help with the literacy, numeracy, other information.
Yeah.
Questions, comments, suggestions? All right.
Great, thank you all.
Great, thanks so much for sharing with us. This is fun.
All right, guys, let's see if I can keep it as succinct as Dan. I'm Anand Iyer, so emphasis on the first level. I'm a faculty in pulmonary, and I'm presenting my K12 project, which, fancy acronym generator.net helped me with this. Early palliative and supportive care in COPD. It's again supported by K12, but it's also supported by Palliative Research Enhancement Project Pilot Award. So I'm grateful to the Palliative and Supportive Care Center with Rodney Tucker, the UAB Lung Health Center. My primary mentor is Dr. Marie Bakaitis from Palliative Care and Mark Dransford from Pulmonary. Other methods mentors, Janet Turan, Talia Ivankova, Nick Dion Odom, he's from Palliative Care, and then Stephanie Ford with coordination of patient recruitment. Hopefully what we'll do in this brief time is talk about the scope of the problem of palliative care in COPD, what we can do to make it, to improve access and sort of integration of palliative care. Talk about the project, my aims, my methods, and if we have time, talk about the prelim results, but we don't have to get to that. So this is a summary slide of one scope of the problem. So COPD affects 15 million people. I'm going to harp on that. I've done that many times at this Friday morning conference. 15 million adults, third leading cause of death, and it's projected to be the leading cause of hospitalizations by 2021. So you're thinking healthcare utilization outcomes problems, but there are also patient-reported outcomes and quality of life issues that COPD patients deal with throughout the spectrum of their disease. And so here's COPD in this. These are all PRO measures of symptoms, and they compare them against other diseases with serious illnesses. So cancer, congestive heart failure, CKD, dementia, and AIDS. So if you look at cancer, for instance, in the first blue, pain is a very big problem that's reported in high frequency in cancer. In COPD, we have dyspnea and anxiety and depression and sadness, nausea, all sorts of things impact a patient with COPD, but they get less interventions on such sort of quality of life measures. And palliative care seems to be less integrated in COPD as it does in cancer. If you look at GOLD guidelines, and that's GOLD is a global initiative for obstructive lung disease, they recommend palliative care. But when you actually read into the guidelines, they're pretty weak. We think it should be done at end of life. They misuse the word palliative care and hospice care and end of life care. They try to define the three. They interchange them incorrectly, and so we're trying to work with that group to make sure that that's clearly stated, because palliative care is comprehensive supportive care that can be used at any point in the disease trajectory, even from the beginning of diagnosis or at the end of life. It encompasses supportive care. We have Sunday here who's, I'll be looking for you for next year. She's a palliative care attending. So it's comprehensive supportive care for disease management, symptom assessment, to end-of-life care, to hospice care. So we just want to make sure that there's a clear, distinct difference between that, and that's something we're finding in our data already. So palliative care is poorly instituted in COPD, particularly even in end-stage COPD, on-home oxygen, hospitalized multiple times. These patients are getting them at a fraction of the referral rate than patients with advanced cancer, despite having the same, if not more, symptom burden. Barriers and facilitators exist, but multiple stakeholder perspectives have not been explored. And we have models that can integrate palliative care early in the disease, but those haven't been developed for COPD. And this is different than self-care management navigator programs. This is palliative care structured interventions. The one model that I based this intervention on was the ENABLE model developed by Marie and her team. It stands for Educate, Nurture, Advise Before Life Ends. It's a palliative nurse coach who uses low tech. So we're going back, we're stepping back. We're not doing iPhone-based. We're doing you have a phone. So telephone-based palliative care intervention. Tested in advanced cancer. It's being adapted to heart failure. It improved quality of life, depressive symptoms for patients with advanced cancer. And there's even a signal for survival. And so when instituted, when you go weekly phone calls with a palliative nurse coach who works you through a curriculum, not just anything, but a curriculum based on a model. Again, that's something I'm learning in developing this K12. Make a model, use it based on theoretical frameworks. Don't just design a self-care program that just throws the kitchen sink at somebody, but have a structure to it. It changes the game. So these nurse coaches use 6 sessions for patients, sessions 1 through 3 based on a COPE model, creativity, optimism, problem solving, expert information. Then they shift to an outlook model, method of life review, preparation for end-of-life personal growth. So you're on the phone with this nurse coach who's working through a guidebook and kind of coaches you through, have you talked to your significant caregiver about this, advanced planning and issues related to your stress and such. But what's amazing about that model was that it incorporated the caregiver as a subject in the project too. So it's not just the patient, but the caregiver as a team. And they went through 4 weeks of the project. So my project overall purpose is just to understand and build a program of inquiry on palliative care and COPD. There are problems. We need to find out what the problems are. Why do they exist in COPD with pulmonologists and palliative care clinicians? And then once we've solved these problems, develop and test the feasibility of the COPD adapted enable model and try to assess barriers and facilitators to this project. So my conceptual framework for this project is here. What you can see in this axis is well-being to distress. Time is on the right axis, on the x-axis. So when somebody gets a diagnosis of COPD, oftentimes these stars represent hospitalizations for exacerbation. Sometimes that's the time when they get diagnosed with COPD. They don't have a spirometry, but they get a hit to their well-being. It doesn't quite come back up. Their lung function is declining. They're having more dyspnea. Their quality of life is going down. The burden to the caregiver is going up. And this period of unpredictability is a huge driver of angst and distress and anger, and it lasts for months to years. And so that outlook isn't expressed to patients in our clinic because we don't know what the outlook could look like for COPD. We can tell you live for years. We have calculations. We have risk prediction models, but it's all over the place, and that drives patients, it drives up the anxiety. Here's where palliative care has been historically implemented. When you're on the vent in the ICU or on BiPAP mask in the intensive care unit on your 4th hospitalization, let's integrate palliative care right there. No, that's not where it needs to be. If you see that trajectory, you compare it to the yellow line. That's the cancer trajectory. Therefore, they're kind of staying as they are for years, and then all of a sudden there's a quick drop and decline in their health. And that's sort of very predictable. You can get your diagnosis, you can predict where things are headed. So the COPD trajectory is an important thing in this concept, and we want to integrate palliative care early. And you'll see that supportive care, that's the comprehensive supportive care for your patient and the caregiver, that needs to start much earlier in the disease process, and then start bringing in palliative care principles about values planning, outlook-based planning. Then integrate end-of-life care, hospice care, bereavement, caregiver support. That's where that needs to happen, but you've got the team already built early on if you can do it this way. So what I proposed in my K12 is a multi-phase mixed method study where we start with phase 1, a concurrent qual plus quan. You'll see that in your methods and mixed methods with Ivankova. Big Q means that that's what you're going to focus on more. Little q means that's what you'll focus on less. We move to prototype intervention development informed by the data collected in phase 1. Then once we have the intervention developed, we go through mixed methods intervention pilot trial, and then we refine the intervention. Each one of those phases has a different aim. We'll focus on phase 1, that's where I'm at right now. The overall aim of phase 1 is to explore stakeholder perspectives on the role of palliative care in COPD, including barriers and facilitators to early palliative care. Then we're going to try to engage stakeholders in the development and implementation of the prototype intervention, and then refine it for feasibility through the mixed methods intervention pilot. So this phase, I'm doing this concurrent, meaning qualitative data is collected at the same time as quantitative data. That data is merged, and then you find what are called meta-inferences, or really cool insight into what's going on. It's a purposive sample, meaning you're specifically targeting different types of patients and their caregivers. I'm targeting 20 dyads, so dyad is a caregiver and their patient, adults with COPD and their family caregivers, and then I want to get the provider perspective. So I'm also engaging 20 providers from pulmonary and palliative care from UAB. We're including sites at Kirkman Clinic, my clinic at Cooper Green. I'm establishing the pulmonary clinic there and the UAB Lung Health Center. We're looking at adults greater than 40 years of COPD. That means you have a spirometry proven COPD, and the moderate to severe number, that's important because what defines early palliative care integration, and that's something that's coming out of the qualitative data. When do we need to start referring people Should it be just these people with severe, very, very severe COPD, or are there some aspects of moderate COPD that also need to warrant qualitative interviews? And the answer to that is yes. Using PROs to help guide us, MMRC dyspnea scale for severe shortness of breath, or home oxygen, or having a severe exacerbation. Now these two right here, home oxygen and severe exacerbation, can be gathered from health records in I2B2, so that kind of does help a little bit. They have to have a family caregiver, they have to be able to speak and read English, and they have no other primary lung disease. The provider eligibility criteria, they're just attendings, faculty members, and fellows in the pulmonary and palliative care divisions. When you do a mixed methods project, you don't just have aims, but you have research questions. So my research questions for this phase have been, how do stakeholder perspectives on palliative and supportive care and COPD align or diverge? Do providers think of this differently than the patients? Do the patients think of it differently than the caregivers? What are the barriers of facilitators, particularly when we want to integrate this proactively and early? And how feasible is the adaptation that I show them to adapt it to COPD? And we'll talk a little bit more about that. But when you design these kind of projects, you have a qualitative arm and a quantitative arm, or strands. The qualitative strand is semi-structured, in-depth interviews, because we're really trying to explore the perspectives. We've debated about focus groups, but you can get a larger sample that way, but you can't get drilled down into really deep issues. And a lot of these things are end-of-life issues and shortness of breath, depression, anxiety. So you really want in-depth interviews. Structured in this kind of way for the interview, what are palliative care needs? What are the perspectives on palliative care in general? Then what are they in COPD? Can we define some referral criteria? When do we need to start integrating it? What are some barriers of facilitators? And then I present the model to all the participants and ask their feedback. I'm getting quantitative data as well, demographic healthcare utilization data prior to enrollment, and some PROs to sort of merge the databases. The COPD assessment test that I administer to the patient, that measures health status or quality of life for COPD. Higher scores are worse. Promise measures for global health and emotional distress. The UAB life space assessment, that tells you your mobility from your home to outside of your town, and my prelim data from other work shows that COPD patients have as restricted a life space mobility as older adults greater than 65 from another study. So shortness of breath and things like that are limiting patients. Then I've developed a acceptability and feasibility survey that I administer after showing them the proposed intervention. Doing in vivo coding and thematic analysis, that's been fun to learn how to do that. Having Marie and Nick, who have done that before, it's been very helpful. It takes a lot of work. You have to learn your mind is in quantitative realm, you're a positivist, as they call it, and you're quantitatively, you're running through the data, but now you're saying, let's read paragraphs of text, let's read pages of interview transcripts and try to make up themes. Then you do descriptive analysis on the quantitative aspect. And this is something you develop. A mixed methods procedural diagram. You see on the left side are qualitative data, on the right side are the quantitative data. What do you want to do on the qualitative? I'm trying to collect interviews, do coding and thematic analysis. I'll generate transcripts and code books. The quantitative side, I'll do intake surveys, feedback surveys. I'll take mean, standard deviations. This isn't a large sample. So what you want to do is take this data from qualitative and quantitative and merge them. Do these joint displays where you have symptom measures of depression, for instance, or FEV1 lung function, and then exemplary quotes of what they think about palliative care from each FEV1. That's where I'm at right now. But this is the entire procedural diagram for what I developed from the course with Ivan Kova. This fits on a page as an appendix, I guess. You can't really fit it on a slide, you're not intended to, but it just shows what I showed you before. Phase 1, Phase 2, Phase 3, and then kind of finalizing it into Phase 4. I have prelim results, so we can talk about those in a minute, but my goal is to take I've enrolled 7 dyads. I've interviewed those 7 dyads, done the qualitative analysis on those, and for 12 providers, 6 from palliative and 6 from pulmonary. So we have a sample size so far of 26, and we have engaged a lot of patients. Most of these are severe COPD on home oxygen with frequent hospitalizations, but we even have some with earlier, more moderate disease. And the summary is, people think palliative care is important, but they're misconceiving of what palliative care is, and that includes pulmonary providers who use palliative care a lot in the ICU, where there's a misconceptions of it. So that's a huge barrier that we're going to have to work around when we're designing this project and try to incorporate it in clinic. And so anyway, we can get to that at another point. My goal will be to take this data to a K23, either from National Institute of Aging or NHLBI in the summer or fall. And we have the feasibility, we'll have feasibility data by that point in the pilot trial to show that that could work for COPD and either compare it to another project or kind of build that intervention even more going forward. So that's what I've got so far.
I think we'll pause and take some questions,
Yeah, sure.
and then we can go into some of the results if that's okay.
That's fine.
If you want to do that. Comments or questions? So I can get us started. So thinking back about that framework you showed, to me showed a trajectory of disease. And so what I'm trying to put together is something in terms of some of the quantitative measures. So what's included in this intervention? You're adapting an existing intervention for a new population. And so just trying to think about within the phases of that COPE piece with those domains, how do they fit into a conceptual model for pulmonary patients? Are those the right things for folks with pulmonary? So they've been developed, right? This intervention has been developed for other populations, demonstrating the palliative care supportive needs, and here are the domains. And so are you able to, in the quantitative aspect of the study, have measures that map to the intervention targets? So just trying to think about conceptually, if someone with COPD, this kind of burden of symptoms, you talk about this anger and this other stuff, and then clearly in that intervention there's structured things. I mean, that map to, I'm sure, existing instruments that have had some validation in terms of people with cancer tend to experience this, that, and the other challenge. Therefore, we have intervention targets. So just trying to think about opportunity to, so love going to the intervention, but has the exploratory work been done to demonstrate that in persons with COPD, the same domains that have been defined and developed into this intervention package, what is their relative impact, right. Perception, from a patient perspective, provider perspective, and then quantitatively, how do these different things influence important outcomes in folks with COPD?
Right, that's a great question. So my quantitative research has used, let's take an example, anxiety and depression, right? So I haven't used the PROMIS measures before. I've been in PHQ-9 and GAD-7 and HADS world, so those these are all validated in COPD, and the research is less so in PROMIS measures. The PROMIS measures are what were used in the randomized controlled trial for cancer for ENABLE in the past, and so they measured that. So that's an important part of this project too, is what are the target endpoints that are ideal for COPD? I didn't include that, but that's also what we're looking at, is that going to be the right measure? So we not only have symptom-based measures like PROMIS measures, but I'm validating the life space in COPD. There are caregiver burden measures that we're including. There are quality of communication and some health literacy measures as well. And the data on those are much slimmer in COPD, so we want to make sure that that's important.
Because I think one suggestion, I like the framework, and there's a lot of folks in the room, like Gabriella and Kaylee and others, that know a lot more about conceptual models and things. But I would think for the extramural K, and again, I don't know, I can speak from my experience in HIV, that reviewers are going to want to see whether it's the health belief, some existing conceptual model with your population with these specific measures where the intervention fits. But again, I don't know. I mean, others that are more with me as well, just trying to think about kind of some of what extramural reviewers might want to see.
Where are you planning on submitting it?
So NIA, or National Institute of Aging, has support for a lot of palliative care type projects like this, and so that would be one. But we haven't. I've directly spoken to 2 program officers from there, but not yet reached out to NHLBI, and so that would be the 2 target locations.
So I'm curious what you're doing with the promise measures. Are you looking for some like threshold that people are meeting, at which point you do something?
Correct. Well, that's part of it. It's first off, it's just it's cross tabulating. So if you convert it to a T-score, you can get sort of population means on the promise measures, and if people score on a higher standard deviation up here, that's severe anxiety, severe depression. Does that map back to experiences described in COPD that are important, that can help guide us to, well, people in severe COPD have high promise measures, high anxiety or high depressive symptoms, and some of my prelim data shows that. But what are they qualitatively describing about palliative care when they're high anxiety or they have high depressive symptoms? Where can we use that to put the intervention, to start the intervention? Should we start putting depressive symptom measures in clinic as triggers to referral to palliative care? Sometimes we don't really need to count on the physicians to do it themselves. So maybe that could guide us to where along the spectrum we need to start. Those palliative care needs become more apparent, and maybe where we need to integrate better.
It seems like the pieces of the intervention, you mentioned that there were two different conceptual approaches to those. I wonder if you might be able to propose certain, theory of change or other conceptual frameworks for like health belief or kind of behavioral theories that might draw on these or similar concepts in each of these models.
Great point. Yeah, that needs to be brought out some more. I have the slide of sort of those conceptual models like you mentioned. I think you had presented one back before about public health in general, so that was a cool model too. But yeah, you're right. That needs. I can bring that out some more. Maybe tie that to why we think this is working. I think Marie has and Nick have. They have done this. So
Yeah.
Just a matter of bringing that out more.
I think you'll definitely find something, but you think about how these specific components might plug into one of those.
Perfect.
Or it could be just a simple basic quality improvement model, like the improvement of health services. This is the end point, right? We're not trying to change behavior. The end point is changing the services, right? And that could be just a basic quality improvement. And what informs that? The provider's knowledge or patient's knowledge or services that bring into the outcome is the improved palliative, the services for COPD patients.
That becomes a really important, I think, question in terms of the structure and the design and the focus. Because if you're talking,
What is the major focus?
what is the focus of intervention? No, this is a great point. I mean, you're focusing on adapting an existing intervention and tailoring it to a new population, which is very different. I think what you're describing is saying this is more of a system-based approach. So I think those are really critical delineations.
That's for the intervention pilot, it's a sort of iterative intervention development design. So you put a few dyads through the project from start to finish. You assess adherence. You assess how many times they've reached the phone calls. Could they actually do the phone calls? Just simple. Those are primary outcomes. It's the feasibility outcomes. And then you refine. You enroll more dyads. You, again, measure things. And you see if those measures are the right ones. And if they're able to complete the surveys. And our COPD patients can't breathe. They can't do surveys for longer than 45 minutes.
And the qualitative method perfectly fits the quality improvement outcomes. It's just and it's basic, and you don't have to go into little specifics of what should be done. Your qualitative approach is going to inform you what intervention you're going to have, but the end point is the quality improvement. You have the goal of incorporating that palliative care into the earlier stages of the COPD. Just like basic scheme like that, I think it would be sufficient enough. And we used one scheme in our, I can send you the conceptual model that we used for our project in cancer patients, if you want.
Yeah, absolutely. That'd be really helpful.
So for the promise measures that you're using, I'm using them as well, and I feel like several other people who use them have difficulty sometimes interpreting them. Like, how are you going to go about saying, what's clinically meaningful, or, they kind of have like a 0.5 standard deviation as their just general value, but how are you?
That's a good point. They have scoring categories on the ones that they've released. So 55 or greater, 55 to 61. There's something 64 to 70, then they put you at mild, moderate, severe is greater than 70. So they do have categories. If you haven't seen that, look those up. Those exist. So that would be one thing to, I don't necessarily think you need to be integrating it for mild depressive symptoms, but we don't know. There may be an important point of improving depressive symptoms at that point. But yeah, so you can find categories for those cutoff points.
I think the promise measures are really designed to measure, they're designed for treatment outcomes. So
Correct.
really measuring like within-person changes in these symptoms. I don't know what the data looks like for like group, I don't know.
Yeah, this is one thing I went toe-to-toe with Marie, or one of my prior mentors on, is I've had experience with the HADS before, and I know what that feels like in COPD, but this is what's been tested in cancer. And so, to your point, it's going to be something I think we'll have to, how do you wrestle with your primary mentor on differences of opinions on what things, were validated in COPD, and can you really find differences in promise measures that are important, clinically meaningful? And that's a great question. So I think I'll have to do a little bit more work about that.
And Kim, your point I think is we should probably just pause there, because I think this idea of within versus between variability is a really important distinction. So when you administer a measure to a sample, statistically you can evaluate how does my score compare, how do each of our scores compare to one another, right? And that's what we oftentimes report upon is how do you score relative to the average or median of your peers, whereas if I heard you right, the promise measures were designed to not look at that between person variability, but within person variability. So longitudinally, how does my promise score today compare to my promise score in 3 months, 6 months, 9 months, independent of how my promise score is relative to everyone else in the room? And I think statistically, a lot of times, historically, a lot of the literature in health services and outcomes research really focuses on the between variability. Most of what you see reported, a lot of what you see reported is how does an individual score relative to the remainder of the sample or some population norm. And I think, in terms of the field, I'm glad you brought this up, this idea of looking at within patient variability over time in a number of different areas has proved really important. So I might be lower than the average, but my delta from time 1 to time 2 is such that it places me at risk for worse behaviors, worse outcomes. So.
Right, cross-sectional data is always flawed with that in that realm, and I've even found that out the hard way with some of the manuscripts I'm trying to submit. Reviewers are looking at, well, why didn't you use the longitudinal aspects of the national data set? Well, they didn't measure that same symptom at PRO at different points. They only measured it at one point, so you try to get back to them. And then you're right, then it's just a cross-sectional snapshot of what that person might have looked like at that point, and rather than a change over time. And so that is a major flaw, but we would be collecting that measure at the beginning of the trial, middle of the trial, after the trial, and then 3 months down the road. So there would be a longitudinal aspect of this in a pilot form. So there could be, we could assess variability. It's just not powered for that.
And that being said, I think people will like that you're using promise measure just because they are the newest, shiniest thing.
They are, indeed.
Is everyone familiar with PROMIS? Big NIH initiative, the Patient-Reported Outcome Measurement Information Systems? Is that the right acronym? Something along those lines.
I don't know what the S is.
I mean, so
huge
initiative, like lots and lots of money from NIH to try to better homogenize and standardize patient-reported outcomes. And so, the idea of, and I think a lot of that work has included in-depth cognitive interviews, assessing a battery of questions, so it's this really in-depth psychometric process of, in different populations, administering a battery of items, and there's all a science behind this in terms of item response theory, and CAT is something, there's just huge science behind developing this, but the idea of trying to develop instruments that could be more standardized And Kaylee, if you know more about it, I mean, share. But I mean, it's a large initiative from NIH, and I think a big emphasis on trying to use these measures where appropriate, rather than sometimes the historical PHQ-9 or AMD. Here's a promised depression or anxiety instrument.
I think it's hosted by, or was developed largely by Northwestern, but they also have like a health, I think it's health measures is their kind of like place where they're bringing promise in, as well as like the NIH toolbox and several other like standardized patient-reported outcomes. And so they're, I would say, mainly free to use. Like UAB through REDCap actually has access to all those measures, so you can use it, the instruments to use it are there, and it'll automatically score it. So it's kind of well available for us too.
They want people to use them.
And the plugs for next week, we've scheduled
A couple weeks.
2 weeks. Dr. Willig and his team are going to be talking about PRO development, or how do you use that. So please come to that session if you're interested, because James has developed an incredible PRO system for 1917 clinic. When we modeled it, it's outstanding, and how that integrates into clinical care electronically is just even better than having to do what we tried to do in COPD clinic of paper administration, which there are barriers to integrating a system like that into Kirkland Clinic. They're doing it separately from the EMR. And so it'll be interesting to sort of pick his brain on how we can improve that at UAB for integration into our system. But come to that one, that's cool.
January 26th, early plug. Wait for the team announcement, and I got the preview. Yeah, no, I'm just thinking, I mean, even if it goes more of this idea of a health services, how do you position this within the framework rather than individual level? If it's possible, because you've got this and it exists, to think about what are the dimensions and domains, and I would think for me to see how they map to what your qualitative work is showing in your quantitative data would help validate the idea that an adapted version of this intervention is the right one for your population.
Okay. Cool, man. That's a good point.
So
Yes,
I think this is a really nice model of the mixed methods methodology. And given that you're about halfway through recruitment and assessment, I'd love to know if you have lessons learned or things that you might do differently or recommend to others who are trying to put that into use here in a very complex health system.
Yeah, so one would be just the idea of doing in-depth interviews versus focus groups. So make sure you choose that correctly from the get-go. 6 to 8, Dan, is a lot of focus groups. Usually they're reach saturation at 3, or if I remember what it was, but there are a lot of focus groups. That's a harder thing than you might think to enroll. Getting qualitative interviews take a lot of time, and they take an immense, even more time to, once you receive the HIPAA compliant transcript, to do the qualitative coding. So that's taking a lot of reading, which, that's, well, I'll do that at 9 o'clock at night when I'm sitting, or my child's running around, I'm qualitatively coding something. So it's been an interesting thing to learn. So lessons learned is make sure you budget for that kind of coding time to just in your day-to-day hours. And then something called saturation is something we're exploring. And when you've got enough people with severe COPD, which I have, of the 7 dyads, I think 6 patients have severe COPD. They're on oxygen, they can barely walk across the room, and they've been hospitalized a dozen times. So that group has unanimously supported palliative care. When you present it to them, this is what palliative care is. It's not hospice care. It's not end-of-life care. It's actually this. This is the national definition. They're like, oh, that's fascinating. Tell me more about that. I would love to learn more. Please, if I had done this before, I would have done. So you get a lot of data, you get it over and over, and it supports it, qualitative data, but now we don't have enough of the moderate people. So we're trying to, that's why we increased the FEV1 threshold to put it up to 80, which is putting you with moderate to COPD or more, or worse, sorry. So that's a change that happened, where we started to look at when we needed to purposely sample less severe COPD people and start talking to them more and saying, well, could we even get to you then when you're stage 2, if you want to conceptualize that way, stage 2 versus 4? Could we start talking to you about palliative care here? What components of palliative care would you be interested in receiving? Maybe more education, maybe more coping with your disease, maybe start to piece out the ideas of planning for the end of life, but don't really make it so heavy at that point. Versus over here, we're talking about hospice care, bereavement care, caregiver support, a lot of stuff that are more for the severe COPD. So that's how that's adapted. So I'm actively looking for less severe COPD. We're reaching saturation for those with severe, so we may not need to get more stories from them because it's the same story. And then now how to do the merging, that's what I'm learning how to do. So Natalia's been huge about that, and Marie's going to help me with ways to sort of put a quantitative survey over here with qualitative quotes over here. So that's what mixed methods is. It's not multi-methods. You're not doing two separate studies and then you're publishing the qualitative and publishing the quantitative. You're publishing them both together. So that's the important thing.
Did you do any kind of in vivo or are you just learning, how are you learning in terms of coding? I mean, it's something that's new, it's part of your career development plan.
Correct.
That's working with your mentors?
Yeah, I did the coursework in qualitative methods, so we did some prelim coding there. Then you learn how to develop a code book with your mentors and your mentor team. You learn how to do quality assurance in qualitative research. You learn to have member checking from your stakeholders. You learn how to have audits where people come in and look at how you're coding things. How do you actually use the in vivo program to read a paragraph, highlight that paragraph, and say, I'm going to call that paragraph the depressive symptoms in COPD. I'm going to call this paragraph access to care for palliative care or something like that. And I'm going to put those into needs. I'm going to put this into barriers. I'm going to put this into facilitators so that at the end I can have these exemplary quotes. So they're teaching me, they taught me, that was part of the development. I'm going to learn from my mentor team how to do this. And up front it was hard.
That's great. Yeah. No.
It was too hard. It was really hard. I didn't even know what I was looking for. I was like, I'll put this word. That's anxiety. He said anxiety, there's anxiety.
Matt.
Yeah, Matt, we got anxiety. No, you have to give the whole paragraph. You have to give the whole quote.
No, in the past, we've sent folks to go, in vivo offers regional trainings and folks have gone to those, but we've also had folks come in and do 2- and 3-day trainings. And I think to your point, there's different levels. I mean, there's levels at the investigator level, there's a certain amount of training, but then also if there's folks who are actually conducting the interviews and doing this qualitative work. So I know in the past we've done this through the Center for AIDS Research. If there's sufficient interest in critical mass, we could look into hosting a similar thing here. I mean, we've done that in the past, and I think it was well attended, and could look into doing that again and seeing if there's sufficient interest in this group. Might we be able to offer something like that that's tailored to the needs? I think so many of us are doing mixed methods and qualitative research and taking coursework, but this is more of an applied. I mean, this is more of a folks coming in that do this and a 2-day boot camp in terms of rolling up your sleeves and the logistics of doing some of this.
And to your point regarding like challenges, this goes to the basic point of here's a quantitative scientist doing quantitative research, and then you present this grant that says I'm going to do mixed methods and put some qualitative. I had reviewers say, why do you need qualitative data? And Natalia will punch him in the face because she's mad, and Dana Turin will do the same thing because they echo these sort of panels that say you don't need as much qualitative data. You don't need that kind of stuff. You just do it. Just put it out there and see what happens. You don't need to go in there and understand perspectives. Even my reviewers on my grant were like, well, do we really need to understand these perspectives? Why, you already know that you're a pulmonologist. You should be able to do this. And so there's a misunderstanding of what the impact of qualitative research is in the world. And so I'm learning that it's huge, that it can actually impact the way I'm delivering care to my patients by understanding what's going on here. And not only from a clinical practicality, but from a health systems measures to health services research. You can learn so much with stakeholder engagement if you interview several admins, for instance, regarding admissions, readmissions, or you can get a better understanding of why there are disparities that exist or why do variants exist. And you're like, oh, okay, I can go from it. So that's a huge challenge that I'm going to be concerned about still as I go to an extramural. Okay, what is the NIH going to look at to say, well, sort of robustness of a qualitative project? And even when you try to publish them, they're 3,000 words, 4,000 word papers versus 2,000 word manuscripts. So it's just a different different. They can have JAMA's published qualitative work. Blue Journal, our main pulmonary, they publish qualitative work, so it does exist. It is a concern that I still have, a nagging concern that no one's getting it, or you have to teach it to your attendings. You have to teach it to the guys that are senior that are stuck in quantitative world, you know.
And I think practically, in a room like this, you have great consensus. And I think to the points of where you're going to submit to, beyond talking to the program officer at NIH, looking at the study section. Because I mean, I've seen a bunch of K reviews and panels, and it's amazing, depending on the composition of the study section panel, how they receive qualitative work, quantitative. I mean, it can go both ways. So in the panels that I go to, there might be one physician. Everyone else is a PhD, typically clinical psychology, you know, and so there's a very different expectation from that study section than a study section that is full of MDs with maybe one or two PhDs or epidemiologists. So I think kind of the value of it, without doubt, and you want to kind of win over the masses. But you also have to be strategic when you're submitting your grant and saying, okay, but and the more you can kind of go through the program officer and look at that study section, and even better if someone else has submitted there before, and get those pink sheets. And so, you know, how did this study section react to
pink sheets?
A summary statement used to be paper copy pink sheets. I'm dating myself. I'm like,
oh man.
So that back pink sheets. It's an old school. White copy goes to the program, yellow copy goes to somebody else, and you get the pink one. So, I mean, you know, I think just any of like the practical, right? Some of the really practical things that come up, because it is in some ways, while we're doing good science and it's rigorous, I mean, there's also a gamesmanship to this.
That's why we talked about for this particular presentation, and kind of even for your T32 works in progress, we'd love to help you guys develop your projects like what you're doing with me here and now. And so that's why we want to kind of streamline it to not necessarily the results, but really harp down to what are your models, what are your frameworks, what are your aims. So hopefully we can kind of set a theme for these going forward. Yeah.
This may be more long-term and may not help you at all, so I'm just going to throw it out there. But coming from our VA quality improvement classes, and you know, if you're going to take more of a quality improvement type spin on this, implementation science is really what they're harping on now for funding and projects and things like that. And if you could, you know, get this model down to where you want it, you do your PDSA cycles, and the next thing is really putting it in. I think if you took the implementation science spin on it and used your qualitative, all your experience and used it for that, you could, I mean, I think that'd be really powerful.
That'd be great. It's you know, that a lot of things are developed, but not, and the problem with D&I or dissemination and implementation is it doesn't get disseminated, it doesn't get implemented. It's just, here's my booklets, let's go to COPD clinic and try to see how these work. I've done all this work. No, I love that idea. It's now, if there can be K funding for implementation science, I'll have to look deeper. I think there are implementation K funding projects, but I haven't spent enough time in that realm of like.
I think there are.
Yeah, Mike, I think also the point of, even if it's not for the K, that, you know, for you who comes in with a master's, a lot of experience published, one of the challenges sometimes is, well, what are the career, why do you need the extramural K? So what do my career development need? So part of it might be a nice way to fit in. I need more formal training in implementation science, so when I do this K scope of work, my R-Series grant is going to be an implementation science grant. So I'm doing this work, getting the career development training,
start writing this.
And I'm poised now to get the ROI.
That's perfect. I appreciate that. That was a good one. Yeah.
And just, I remember that this also reminds me of the shared decision making.
Yep.
Indeed.
So you might want to look at those conceptual models that are leading, like shared decision making, leading to quality improvement.
Perfect. I need to help behavior change, shared decision making. Not those two.
Pick one.
Pick one. I gotta pick one. I can't make a merge one.
Yeah. Rosie, kitchen sink, yeah.
Here's the kitchen sink.
I got these 9 models.
I got these 9 models.
My global one,
Yeah, we solved the world problem.
We're
taking the brain. We're taking human nature. All right, that's probably good for today, guys, but I appreciate all the feedback, and hopefully we stimulated some discussion. We're going to be like these going forward and help you guys out too.
Just a curious question.
For sure.
How long does it take you to read this thing like that? For a person?
Per person, oh gosh, it could be several
hours.
hours.
And it get better, of course.
Yeah, no, it's gotten faster now with the 5th or 4th or 5th time. You read a few transcripts and then you're supposed to kind of reevaluate if you're asking the right questions in your interview guides. And so, couple of hours probably. I got it down to an hour, maybe a script or something now, but it depends on how much they talk. And as a physicians, we interrupt people, within 10 seconds or within 40 seconds, what was the data? So 3 seconds. Oh, so tell me about why you came here. Okay, no, let's get to your symptoms. That's not what we're supposed to do. You're supposed to say, describe to me what it was like living with COPD. And then they go or they don't go, and then you have prompts. And I've had people generate 5 minutes of one question, 5 minutes, but they just started talking about their life with COPD because they had so much on their shoulders. So it's been fascinating with that. Hey, Rick.
I'm wondering, in the dyads, and interviews and also in the focus groups, you have done focus groups, right?
I have not done focus groups.
Oh, okay. Well, do you see, what's your racial distribution? Do you see about equal amounts of white and black patients with COPD, or does it go?
That's a great point. We have, this is a majority white sample, but I'm purposely sampling African American diets from the Cooper Green Clinic. It's because we want to understand their level of understanding of palliative care and what they even know about hospice care, and where, we want to make sure it impacts them too. So we are seeing a lot of white.
So I just finished 5 focus groups with COPD patients, and I got help from the recruitment and retention shared facility to recruit them, and they oversampled African Americans so badly. I mean, 3/4 of my sample was
Really?
In a disease that's primarily white. So I'm just I don't know, worried about that. I wonder what ends up in your sample.
Yeah, I think it's going to play out to be mostly white. So far, there's 5 diets that are white and 2 that are African American. Importantly, too, I've separated the patient from the caregiver to understand the perspectives individually, and so they don't have them influenced by one another being in the same room together. So I'll have one patient and then the other one's doing surveys, and I switch them out and kind of talk individually, and then kind of see how that data goes together.
So, and this is patients receiving services somewhere here in Birmingham, right?
Correct. Well, Kirkland Clinic.
Okay. So something maybe you want to keep in mind when you get to the focus groups, when you start doing focus groups. It so happened that my focus groups were racially stratified. I didn't mean to, but the way they recruited was just kind of weird accident. And I see very different results from these groups.
Interesting.
Just throwing it out there, FYI.
And from our data from COPD Gene, these different cities have totally different racial breakdowns. And if you could be describing the Birmingham population with COPD and our air pollution and all the other things that go on in Birmingham versus Denver, where there's 99% white COPD patients, versus Temple, where there's 70% black. And so it is. That's really fascinating that they oversampled that way. Maybe we'll see. I'd be interested to see how much different that data becomes. Regarding geocoding and sort of.
And as for models, I've just submitted a pilot project on caregiver burden and cystic fibrosis. So.
And see that? Oh, nice.
So I mean, there is some overlap because yes, the population is younger, but it faces similar uncertainty as to the duration and course and trajectory of disease. So I can share it to see if you're interested to see what models I use there, and if that's useful for you.
Oh, excellent. Absolutely. Mine.
And I'm going to apologize in advance, this may be really nitpicky, but
Go for
for your quantitative analysis, folks from the same dyad are going to be more likely to be similar than not, and then dyads from the same clinic, so Cooper Green or Kirkland, are going to be more similar than not.
Okay.
And have you thought about how you're going to take that into account, if at all?
I have not thought about that. It's going to be point blank. So how should I be thinking of that? I mean, it's first up, it's not necessarily that I'm looking for, I didn't sort of power it for the quantitative strand, right, to say I'm going to look for differences in COPD assessment test scores. So I'm going to get 20 diets, that'll be 20 patients, so that's a really small sample. so I may not notice any statistical difference. But I haven't really even conceptualized that at all. I could look and start to see if there have been, if that theory that you're pointing out is actually existing. Maybe need to see if they both share the same amount of depressive symptoms and life space restriction or something.
Are you quantitatively assessing the caregiver?
Yeah. I'm measuring the same, so I'm measuring not the COPD symptoms, but all the other ones on the caregiver too. And I've shown the caregivers are equally as restricted as COPDers, so as the patients themselves, so that's pretty fascinating.
And so the basic premise that most of our statistical tests assume that we have independent observations,
Right.
and that if there's any type of dependency, statistically there's ways to account for that.
A lot of your observations are sort of selecting in multiple ways, right? Because your observations from the same dyad are going to be more similar than not.
Mm-hmm.
Your observations from the same clinic are going to be more similar than not. And so, one thing to do, because you have Kirkland, Cooper Green, and one other, right?
Yeah, it was a lung health center, but they are seen at Kirkland predominantly for their care. So
Okay.
just two major ones.
So that makes it easy, right? Because then you can just have one binary variable that's basically like 1 of Kirkland, 0 of Cooper Green, for example. The dyad one gets a bit trickier because you could do something similar, but because you have so few observations, you're limited in degrees of freedom.
Correct.
And so it's something I would think about is, do you want to, analyze all of them together, and if so, that dependency, particularly for the dyads, because they're likely living together if it's a caregiver, you're going to need to take that into account somehow. And the other way to do it would be like a hierarchical model, where you say, okay, I know that the pair is nested in this dyad, but again, you're limited on observations. But I think if you don't take that into account, it may it has the potential to bias some of your results.
Okay. Thanks for that comment.
Stuff on dyadic modeling.
Say that again.
Dave Kenny has a lot of resources on dyadic modeling.
Oh, awesome.
Cool.
Do you want to take that?
Beyond Bound and Kenny's sciatic model.
Yeah, Dave Kenny. And we've got offers like workshops on dyadic modeling.
Cool. Awesome. Cool. Great. All right.
That's a great, guys. So I think going forward, if it's okay, I think you guys did a tremendous job kind of setting a template. What we'll do is propose, for future works in progress, maybe you can put out there kind of like a 10-slide template. By no means want to be overly prescriptive, but just the idea, here's a general structure. I think worked really well today. Encourage folks to kind of follow some of that structure so we can maximize. I think these are great sessions, and this was a great way to do it. So thank you both for doing it.
Thanks, bye.
One thing I saw at the end of the Kumar time, quotes from this in the presentation. It was the coolest thing I've ever seen. So I think you're able to have an idiot. The IRB, she had to have a token, get consent, and consider PHI. It was really, that's what somebody called in a presentation. Yeah. And it's always do you read it yourself, or do you have an audience and everything? Yeah. And when I had to reading the quote, when I got to the middle of the presentation, I'm like, my subscribe, I've seen it. In years, I've never seen anyone do it well. Whether it's like read it yourself or you 5 weeks. So I thought it was just, I've never seen it before.